Okay, let's dive right in. Today we're tackling necrotizing enterocolitis, NEC. It's a condition that, well, it causes a lot of worry in neonatal intensive care units, and you've brought us some pretty focused revision notes on it.
That's right. The goal here is really to take these notes and pull out the critical high-yield information.
Yeah, helping you get a super clear picture of what NEC is, especially when it hits those incredibly vulnerable premature babies. Think of this as like your shortcut to understanding the essentials from these sources.
Exactly. And what's striking right away, I think, is how the notes frame it. The most common gastrointestinal emergency in neonates.
Wow. So not rare, particularly for preemies.
Definitely not rare in that group.
Okay.
So let's start where the notes do the definition. What is NEC, fundamentally?
Good question.
It's described as a serious disease affecting the gut, primarily in premature infants. The core problem is inflammation and necrosis.
Necrosis meaning tissue death.
Precisely, tissue death within the intestines.
That sounds, yeah, incredibly serious. And what would you actually see? What are the first signs the notes mention?
Well, the initial symptoms listed are things like feeding intolerance, so the baby isn't taking or keeping down fees well.
Oh.
Abdominal distension, the belly gets swollen, puffy, and bloody stools.
Right, those are definite red flags. And the notes seem to highlight how quickly things can go downhill.
They do. It can progress, sometimes rapidly, to things like discoloration of the abdomen, perforation.
Perforation like a hole forming in the intestine.
Exactly. A hole, which is a massive emergency. And also peritonitis, where the lining of the abdomen itself gets inflamed.
So it can be a really steep decline. The notes really hammer home its significance as that most common GI emergency, hitting premature infants, especially low birth weight ones, the hardest.
Yeah, and it's worth just flagging what the source material says early on. Diagnosing and treating NEC can be really quite challenging.
Which makes you wonder, okay, why does this happen? The notes move into etiology, the causes, and they're pretty upfront, aren't they?
They are. The exact cause. Still not fully pinned down. It's generally considered multifactorial.
Multifactorial, so a combination of things, not one single trigger.
Correct. A mix of contributing factors.
Okay, so what factors do the notes actually point to?
Key ones mentioned are intestinal immaturity, which makes total sense for preemies, right? Their guts just aren't fully developed.
Makes sense.
Then there's ischemia, which means reduced blood flow getting to the intestines.
Okay.
And also an abnormal inflammatory response happening within the gut itself. It seems like these things kind of converge.
Right, so you've got this immature gut, maybe it's not getting enough blood flow, and then it sort of overreacts with inflammation. It sounds complex.
It really is, and the notes actually do a good job breaking down who is most at risk, kind of grouping the risk factors.
Ah, okay. How do they categorize them?
Well, they look at maternal factors first. Things like drug abuse during pregnancy, Chorioamnionitis, that's an infection of the membranes around the baby.
Right, I've heard of that.
And also HIV-positive status in the mother.
Okay. What about fetal factors? Things specific to the baby.
Prematurity itself, obviously, is huge. And also congenital abnormalities, especially if they affect the heart or the GI system.
And what about during the birth process itself?
Yeah, things that cause low blood flow or poor perfusion around the time of birth.
Yeah.
The example given is placental abruption, where the placenta detaches too early. That can definitely increase the risk.
And this is interesting. Aspects of the neonatal care after birth can play a role too.
Yes, that's a key point in the notes. Things like needing respiratory support, certain medications. But here's a really critical one they highlight: the type of feeding.
Ah, feeding. How so?
Preterm formula specifically is listed as increasing the risk, whereas breast milk is noted as being protective.
Wow. That's huge.
Yeah.
Something so fundamental potentially making such a difference.
Absolutely. Lack of breast milk is explicitly there as a risk factor. The notes also mention, though it's much less common, that full-term infants can get NEC.
Oh, really? Even full term?
Yes, but it's usually associated with other significant problems. Things like perinatal asphyxia, lack of oxygen at birth, polycythemia, too many red blood cells, certain congenital heart defects, or bowel issues like Hirschsprung's disease, or even specific conditions like cow's milk protein, enterocolitis, or G6PD deficiency. It suggests that even in termer babies, there's usually some other major underlying stressor involved.
That's a really comprehensive list. It paints a picture of vulnerability. So if we bring this back to how the disease actually develops the pathophysiology, the notes, again, stress that multifactorial nature, don't they?
They do, yeah, and they kind of circle back to those common risk factors we just talked about.
Hmm.
Low gestational age, low birth weight, chorioamnionitis needing mechanical ventilation.
Right.
They also add a few other potential factors into the mix here, maybe a genetic predisposition, issues with how the tiny blood vessels in the gut regulate flow, that's the microvascular tone bit, and abnormal colonization by gut bacteria. But the core message from the pathophysiology section in these notes seems to be why preemies are so susceptible. It's because they're missing several crucial defense mechanisms that a mature gut would have.
So their gut is just fundamentally less equipped to handle the challenges after birth.
Essentially, yes, more vulnerable to injury.
Okay. Now, given that a swollen belly abdominal distension is a major sign, clinicians must have a whole list of other things it could be, right? Things they need to rule out.
Absolutely. And that's where the differential diagnosis section in the notes comes in. It provides, a pretty lengthy list. It really underscores how tricky the diagnosis can be.
I bet. What kind of things are on that list?
Well, when you see abdominal distension in a preemie, it could be serious infections like sepsis, could be different kinds of bowel problems like volvulus or malrotation.
Or the bowel twists.
Exactly, or it's not positioned correctly. Or intussusception, where it kind of telescopes in on itself. Or even infections like pseudomembranous colitis or a blockage like meconium ileus.
Okay, quite a range of gut issues.
Yeah, and beyond that, they list blood-related things like hemolytic disease, or maybe the baby swallowed some maternal blood, structural heart problems like coarctation of the aorta, other infections like meningitis or a UTI, or even simpler things like reflux.
Wow, so that symptom alone really requires a careful workup.
Definitely, you can't just jump to NEC.
Let's shift gears a bit and look at the scale of this problem. The epidemiology section gives us some numbers.
It does. The notes provide UK-specific data, suggesting it affects around 2–3% of babies in UK NICUs overall, but the incidence is much higher in preterms.
How much higher?
Listen to this figure. For infants weighing less than 1,500 grams, the very low birth weight, or VLBW, babies, the incidence jumps somewhere between 10 and 12%.
10 to 12%, so roughly 1 in 10 of those tiniest babies.
Yeah. And a UK study from 2017, cited in the notes, showed a really strong link with gestation. Incidence was as high as 11% for babies born at 24 weeks.
11%.
But it dropped dramatically to just 0.5% for babies born at 31 weeks. So the earlier the baby, the significantly higher the risk.
That's a stark difference.
It really is. The notes also mention there's quite a bit of variation globally. Even looking just at infants under 28 weeks, the reported incidence ranges widely depending on the country: Japan, Australia, Canada, the US, Poland.
That's interesting. Suggests maybe local practices or population differences could be playing a role.
Potentially, yeah. It's complex.
Okay, so we understand what it is, the risk factors, how common it is. What does it actually look like day to day? The clinical presentation section digs into the signs and symptoms more.
Right. So those core signs we mentioned earlier are key. The abdominal distension, the bloody stools, the feeding intolerance.
Got it.
But the notes add other signs that suggest the baby is becoming systemically unwell. Things like lethargy, temperature instability, either too high or too low, and signs of breathing trouble like apnea, pauses in breathing, or bradycardia, a slow heart rate.
And is there a typical time this tends to appear?
For preemies, the notes say it often shows up around the 3rd week of life. But it's variable, could be earlier, could be later. And a really important point the notes make is that the symptoms can be quite variable and sometimes non-specific. That's part of the challenge.
Right. So what might a clinician find on examination?
They might actually see loops of bowel through the thin abdominal wall. They might notice changes in the stool pattern or consistency, obviously the blood we mentioned. Bilious vomiting is a worrying sign, that green or yellow bile vomit. They might hear decreased bowel sounds through the stethoscope, see redness, erythema of the abdominal wall itself, or even feel a mass or detect fluid in the belly, which is called ascites.
And those systemic signs you mentioned, the lethargy, shock, apnea, temperature problems, those really indicate how severe things are getting.
Exactly. They're critical indicators of the severity of the illness.
So with all those possibilities and variable signs, how do doctors actually confirm it's NEC? Investigations must be key.
Absolutely crucial. The main diagnostic tool highlighted in the notes is the abdominal X-ray, plain films of the abdomen.
What are they looking for on the X-ray?
Specific worrying signs. Things like dilated loops of bowel suggesting a blockage or lack of movement, swelling or thickening of the bowel wall itself. And then the sort of classic finding, pneumatosis intestinalis.
Pneumatosis, that sounds technical. What is it?
It's basically gas within the wall of the intestine, not inside the bowel lumen where it should be, but in the actual tissue of the wall. It's a really strong indicator of NEC.
Okay, gas in the bowel wall. Got it. Any other key X-ray findings?
Yes, the really severe ones, pneumoperitoneum, that's free air floating around in the abdominal cavity outside the bowel, that almost always means a perforation, a hole.
Right, the emergency scenario.
Exactly. And they also look for gas in the portal vein system, the veins draining blood from the gut to the liver. That's another poor prognostic sign.
Okay, X-rays are central. What about blood tests?
Vital, too. Mainly for monitoring inflammation markers like C-reactive protein or CRP and checking for acidosis, too much acid in the blood.
And are there blood results that suggest really severe disease?
Yes, the notes mention things like severe or persistent low platelets, thrombocytopenia, low white blood cells, specifically neutrophils, neutropenia, or problems with blood clotting known as coagulopathy. They also mention tracking CRP levels serially can help monitor for later complications like strictures or abscesses.
Makes sense. What else?
Stool cultures might be done looking for specific pathogens, and ultrasound is mentioned as a useful tool, partly because it avoids radiation.
What can ultrasound show?
It can give a good look at the bowel wall thickness and its appearance, check for fluid collections, assess whether the bowel is moving peristalsis, and even look at blood flow using Doppler.
Okay. Any other imaging?
The notes briefly mention other techniques being explored, like contrast studies or MRI, but really X-rays and maybe ultrasound are the mainstays currently. They also touch on research into biomarkers, like looking at metabolic profiles to try and diagnose or predict NEC earlier.
Interesting. And this section also introduces the idea of staging NEC, like classifying how severe it is.
Yes, that's really important for guiding treatment. Often using a system like Bell's staging or a modified version, it combines the clinical signs with the X-ray findings.
How does that work?
So stage 1 is basically suspected NEC, where the signs are quite nonspecific, maybe just some feeding intolerance or mild distension.
Okay.
Stage 2 is definite NEC. IIA is mild definite, with more specific signs like absent bowel sounds and that pneumatosis showing up on the X-ray.
Right, the gas in the wall.
Exactly. Stage IIB is moderate definite NEC, adding things like mild acidosis, maybe some tenderness or redness of the belly wall, and more extensive pneumatosis.
Get more serious.
Definitely. Then stage 3 is advanced NEC. EA means the baby is severely ill systemically, maybe signs of shock, worsening acidosis, significant abdominal wall inflammation, plus specific X-ray signs.
Like it?
Stage IB is the most severe advanced stage, essentially meaning perforation has occurred. So deteriorating vital signs, signs of peritonitis, and usually that free air pneumoperitoneum visible on the X-ray.
That staging seems absolutely crucial for deciding what to do next.
It is. It directly informs the management approach.
Okay, so let's talk about that. Management. What do the notes outline for treating NE young once it's diagnosed or strongly suspected?
It's really a multi-pronged approach. The absolute cornerstone, the first critical step, is complete bowel rest, meaning stopping all feeds, completely nil by mouth. This gives that inflamed, injured gut a chance to rest and hopefully heal.
Number 1, stop feeds. Got it. What else?
Then supportive care is key. 4 fluids are essential for hydration and providing nutrition since the baby isn't feeding. Antibiotics are started immediately.
What kind of antibiotics?
Usually a broad-spectrum combination given intravenously, often for 10 to 14 days, to cover potential bacterial culprits. And supportive care also includes pain relief, analgesia.
Makes sense. What about for the more severe stages?
Well, for more severe cases, particularly stage 3, management often involves surgical intervention. If the baby is having significant breathing problems like apnea, they might need to be intubated and put on a ventilator.
Right.
And feeds, when they're eventually restarted, it's done very gradually, often only beginning 7 to 10 days after the gut seems to be recovering.
Okay. The notes go into a bit more detail on specific interventions too, right?
They do. So that nil by mouth is strict. Often an NG tube nasogastric or OG tube orogastric is placed not for feeding but for suction.
Suction, why?
To continuously drain air and fluid from the stomach and upper intestine. It helps decompress the bowel and reduce distension. Antifungals might be considered if the baby's been on antibiotics for a long time or isn't responding as expected. If there's significant fluid buildup in the abdominocytes, they might need to drain it with a needle, which is paracentesis. If the baby goes into shock, they'll need intensive support, potentially medications called vasopressors to maintain blood pressure, and treatment for complications like DIC, that clotting problem.
And surgery, when is that typically needed?
Surgery is generally indicated if there's clear evidence or high suspicion of perforation that free air on X-ray, or if there's concern that part of the bowel has become necrotic, meaning it's dead tissue that needs to be removed.
Okay. Is surgery the only option then?
The notes mention peritoneal drainage as a less invasive alternative, especially for very small or unstable babies. It involves placing a drain into the abdomen, but they do add that more research is needed to really compare its effectiveness against primary surgery.
I see. And recovery, you mentioned restarting feeds slowly.
Yes, very slowly and cautiously, typically waiting until about 7 to 10 days after the pneumatosis on X-ray has resolved, suggesting the acute inflammation is settling.
It sounds like an incredibly intense period medically and sometimes surgically. What's the outlook? What does the prognosis section say?
Yeah, the notes are quite sobering here. The mortality rate is significant. It's quoted as ranging from 20% to 30%.
Wow, up to nearly a third don't survive.
It's a very serious condition. And even for those who do survive, there's a substantial risk of serious long-term complications.
That's high.
Things like intestinal strictures. These are narrowings that can form in the bowel as it heals, potentially causing blockages later on.
Okay.
Short bowel syndrome is another major one. If a large amount of intestine had to be removed surgically, the baby might not have enough left to absorb nutrients properly, leading to lifelong dependence on IV nutrition or complex feeding regimens.
That sounds incredibly challenging.
It is. And unfortunately, neurodevelopmental disabilities are also listed as a potential long-term complication for survivors of severe NEC.
Oh, dear. So the impact can extend beyond the gut.
Yes. The notes do circle back in this prognosis section to re-emphasize the importance of human milk feeding as a key prevention strategy.
Right, they came up in risk factors too.
Exactly. They also list other potential prevention strategies being used or studied, things like probiotics, giving antenatal corticosteroids to the mother before a preterm birth, and aiming for specific oxygen saturation targets in premature babies. But overall, the summary of the prognosis is that it carries significant mortality and a high risk of serious long-term problems, particularly for the lowest birth weight infants.
And finally, just to be explicit, the notes have a section listing those potential complications together.
They do, yeah. It essentially summarizes what we just discussed. Intestinal strictures, short bowel syndrome, those neurodevelopmental disabilities, ongoing growth and nutritional problems, and an increased risk of other gastrointestinal disorders later in life.
It really drives home that even for babies who pull through the acute illness, the journey might be far from over.
Absolutely. The impact can be profound and lasting.
Wow. Okay, that really was a deep dive into necrotizing enterocolitis, drawing heavily on your revision notes. We've covered quite a lot of the definition, the complex web of causes and risk factors.
How it presents clinically, the crucial investigations, and that staging system.
Right, the intense management strategies, both medical and surgical, and then the challenging prognosis and those potential long-term complications.
It really highlights what a major, formidable challenge NEC is in neonatal care. Underscores the vulnerability of these premature infants and just how complex their developing systems are.
It absolutely does. So, thinking about everything we've discussed, pulling from these notes, given how multifactorial NEC is and how tricky it can be to predict, diagnose early, and manage, what do you think feels like the single most promising area for future research? Is it trying to prevent it happening in the first place, getting much better at spotting it super early, or developing more targeted, maybe less damaging treatments once it's actually started?
That's a tough question because progress is needed on all fronts, really. Better prevention would obviously be ideal. Earlier, more specific diagnoses could allow for less aggressive interventions, perhaps. And more targeted treatments could potentially reduce mortality and long-term damage. It's critical work.
It absolutely is. Any advance would make such a difference for these tiny patients and their families.
Definitely.
Well, thank you for joining us for this deep dive into your notes on necrotizing enterocolitis. We really hope going through it this way has helped clarify and consolidate this complex, important topic for you.